Hello. हाँ 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 बिल्कुल बिल्कुल ਤੁਹਾਡਾ ਵੱਡਾ ਖਾਣਾ ਲਾਹੌਰ ਕਿਸ ਦਿਨ ਕਰੀ हाँ सर ठीक है चलो ठीक है एक सेकंड होल्ड करना सर क्योंकि
हाँ जी सर।
वसीम साहब ने
हाँ जी, लाए तो सारे ने।
पहले किधर शुरू की जी साहब लाइन ठीक हो गई ठीक है हाँ जी पहले गए डॉक्टर कृष्ण जी डॉक्टर सोई शुरू करी बंदे सर बैठे फिजिकली देख बैठे इंशाल्लाह थैंक यू थोड़ा सा मुझे कर दीजिएगा नहीं ये लैपटॉप जी बस दैट
Good morning, ladies and gentlemen from various parts of the world. I think there was a brief hiatus of this webinar or seminar on selected topics in spine surgery. This week we are having discussion about a very important subject, which is osteoporosis. As you know, that with the increasing age, the number of patients having osteoporosis and osteopenia and sarcopenia is quite a huge number. And the pathological fracture because of fall, because of minor trips and minor falls, it's tremendous. The lot of elderly, they sustain fracture of their wrist, their hip, their spine, and that results into various degree of morbidity and at times mortality. And if you go for some kind of stabilization, instrumentation, or other technological correction of the deformity, the osteoporosis, which is basically a very rarefied bone which occurs with age and hormonal changes which comes with age, poses a significant problem. The implant doesn't hold there, the bone collapses, and even if you reinforce it, it does create a problem with the adjacent vertebrae. And so to discuss all these things, we have a number of speakers from Japan, from Pakistan, and our colleagues in ARMY. They are going to present their talk and thoughts about osteoporosis or osteoporotic fractures of the spine. And the first speaker is Professor Shunji Tutsui. Yeah, he is associate professor in Department of Orthopedic Surgery, Wakayama Medical University, Japan. And yes, you can hear? Dr. Shunji.
Please switch on your mic.
Please switch on your mic.
Sorry. Yeah. Can you hear me? Can you hear me?
Can you hear me, Professor Shunji?
Yes. Yes.
Good.
How about you?
Yeah, Professor Shunji is here as the first speaker. He's associate professor of orthopedic surgery in the Department of Orthopedic Surgery in Wakayama Medical University, Japan. And he's going to talk about surgical considerations and the international perspective. So I think,
Hello.
without delay, I think we're already delayed for some time. I'll request Professor Shunji to please start his talk. Thank you.
Okay, thank you. So I'd like to share my presentation.
We can't hear you.
Oh, no.
Dr. Shanji, we cannot hear you.
Oh, okay.
I
Yeah,
think,
yeah. I
there
sent
must be some
my
voice
presentation
problem
this morning.
on your side.
Yeah,
We
please.
can hear.
I sent my presentation this morning. Do you have my presentation?
Dr. Shanji,
Yes.
we cannot hear you.
Okay.
Actually, we
Okay.
can.
Yeah.
Our side is okay.
Yeah.
Nadeem, can you hear me?
Yes, I can hear you. So,
I think something is wrong on their end.
oh, could could you?
Yeah, I'll just make it call.
Hmm.
Hero?
Hello.
Oh, Hero, आ गया?
सर ਤੁਹਾਨੂੰ ਆਵਾਜ਼ ਨਹੀਂ ਆ ਰਹੀ ਸਾਨੂੰ ਸਾਰਿਆਂ ਨੂੰ ਆ ਰਹੀ
आ रही है?
ਸਾਨੂੰ ਆ ਰਹੀ
आ रही है उसको. Dr. Shanji, okay, start speaking. I think probably it should be okay now. Yeah, it's okay.
Can you see my presentation?
Yeah, please.
Okay.
Yeah, we can hear you.
Thank you. Yeah, I sincerely appreciate the opportunity to join this symposium. I thank all members. Okay.
Okay.
So,
We can hear you.
can you hear me? Okay.
Yeah, okay.
Okay. Yeah, this is my disclosure. I have nothing to disclose regarding my presentation. So the proportion of people aged 65 years or older has been rapidly increasing, not only in Asian countries, but also in the world, which is known as entering aged society. So more older people, especially women, tend to suffer from osteoporosis after menopause, leading to the vertebral fragility. So osteoporotic vertebral fracture, usually called OVF, is the most common type of osteoporotic fragile fracture, which causes pain and disability and increased mortality rate. So OVFs are usually benign, and conservative treatment, including analgesics, brace, and anti-osteoporotic drugs, is gold standard. However, limited evidence is reported, and in some patients, conservative treatment does not achieve sufficient bone union. So the surgical indication of the surgical treatment includes pain refractory to conservative treatment, pain resulting from the delayed union or pseudoarthrosis, and progressive vertebral collapse and or kyphotic change. So the several studies have investigated predictors for potential risks for non-union, which suggested that the diffuse low intensity on T1 MRI and confined high intensity or T2 MRI were associated with non-union. So additional studies corroborate these findings. So we take MRI in addition to plain radiographs in almost all cases to determine treatment strategy, conservative versus operative. So as everybody knows that percutaneous VKP is a minimally invasive surgical treatment. So when compared to conservative treatment, superior or pain reduction and improved disability was reported for BKP. So since the prognosis of fractured vertebra can be estimated effectively using MRI, so BKP should be performed in the early period after fracture to obtain a better clinical and radiographic outcomes. So in patients with risk factor for progressive collapse or kyphotic change. However, differential effect may be a problem using BKP because it can lead to a loss of kyphosis collection. So recently, vertebral body staining, which is called VBS, system has been introduced. So in addition to the pain relief, a collapsed vertebral body can be effectively restored in patients with acute compression fracture. For another option, vertebral body replacement may be necessary for patients. Recently, expandable cage with wide foot plate has been introduced. So we usually use this system in patients with pseudoarthrosis and or kyphosis to relieve pain and restore spinal alignment. When this cage is used, short segment fusion can be achieved. However, vertebral body replacement has greater invasiveness even if the expanded cage with wide foot plate system is used. Recently, anterior-posterior fusion using lateral interbody fusion cages without corpectomy has been reported. This is another anterior-posterior technique without corpectomy using leaf combined with BKP. Another recent option is a fenestrated screw. This screw has been developed for the augmentation of pedicle screw fixation using bone cement in osteoporotic vertebra. So we can put cement into the vertebra. This is a less invasive technique using fenestrated screws combined with BKP. Leaf also can be performed concurrently. When using the fenestrated screw, we should take care of issues regarding cement leakage. It tends to occur on the right side under the anatomical consideration. In addition, we should have sufficient distance from screw tip and the lateral wall of the vertebral body. Yeah, so anyway, we recently have several surgical options, and we should combine them to obtain sufficient outcome less invasively. Thank you for your attention.
Thank you, Dr. Shinji. Very good presentation, and it gives you ideas to reinforce the osteoporotic vertebrae. Let me say that these are just mechanical devices which correct the deformity and stent the collapsed vertebra to a certain extent. But you know, the original disease for which osteoporotic fracture has occurred, that remains there. What do you suggest or recommend any treatment to take care of the other vertebrae or the adjacent vertebrae? Because once you put a cement there, once you put a fenestrated screw, or once you put a VBS or stenting device, especially the one which is jacked open, it produces the pressure and concentration of stress on the adjacent level. And since that vertebra is equally diseased as compared to the one who has collapsed, uh, how do you address these junction problem? How do you address the osteoporosis in general? As is there any treatment or anything or something new in putting a sort of some kind of material into the vertebral body instead of bone cement, which can help in restoration of not only the bony structure but also help in restoration of the vitality and the kind of vigor of previous bone which was there before fracture or in the earlier days. Yes, Professor Shundi?
Oh, thank you. So yeah, but I think the most important part for in the management of the osteoporosis is patient function before fracture. Yeah, and we also consider the bone quality as well as muscle quality, vertebral muscle quality. So the age. And frailty condition, yeah, all of them should be considered to choose the best option for the patient. Yeah.
But is there any new material which has come up as compared to the bone cement, which is not a good material?
Yeah, but yeah.
Yeah. Is
Everyone knows that. Yeah.
Is
That
there anything new, like you have kind of silicone-based cement, or you can have sort of a strontium-laced cement, which are kind of composite bone cements, which provide not only mechanical support but also some stimulative effect on the osteoblast in the fractured spine or in the spine which is already diseased. Do you use those cements?
yes, I do. Yeah, cement. Yeah, because it is put into the vertebra less invasively, so I prefer cement.
Okay, Vaseem, you have any comments on that? Sorry, I cannot hear.
It was
Yeah.
a good
Okay.
presentation, I must say.
Thank you.
Thank you.
Pleasure.
No, I think we'll be discussing all these points further in the coming talks.
Yeah.
And,
Okay.
yeah, and we'll wait up for that.
Okay. Thank you, Thank you very much, Dr. Shunji. We really appreciate your talk and presentation. I understand that it's early morning, or it's maybe late in the evening in Japan. And I understand that you waited for us. I mean, there was some technical glitch here in connectivity. Thank you very much for your patience and your understanding. I really appreciate it. Thank you
Yes,
very
thank
much.
you. Thank you very much.
खिजर साहब
सर
ਤੁਹਾਡੀ ਸ਼ੁਰੂ ਕਰ ਲਈਏ ਫਿਰ
दूसरी कर दो सर
हाँ चलो now we have a young man Khizr Ghalib he's orthopedic and spine surgeon in General Hospital Lahore and he's going to talk about reinforcement technique in fragile bone fractures. So I think this is very important because there's so many techniques, so many implants, but I think to my mind, the basic disease is still relatively poorly addressed. The osteoporosis, you have to treat the, like CVA. If you have CVA because of hypertension, you don't treat CVA. CVA, you treat it immediately with whatever appropriate means you have, but at the same time, you treat hypertension so that it doesn't produce any further episodes or events which similar to which led to CVA. So similarly, osteoporosis, once you have a fracture, osteoporotic fracture, whether in the vertebra or in the hip or the wrist, you still have to treat the basic underlying skeletal disorder, whichever way, whether it's a hormonal treatment, whether it's anabolic treatment, or some other treatment. At the same time, you still looking, and the answer is still alluding that you have to reinforce the collapsed vertebra or the fractured vertebra, and you need to reinforce it with a substance which is inert, which is regenerative in its potential, and it can stimulate the osteoblast so that there is new bone formation, and it does not just stay there as a blob of some inert material, which creates its own problem with passage of time. So I think we are looking, and hopefully with passage of time, the new biological scenario is on the horizon, and I think the new drugs or the new some kind of paste will come over the market and will replace the existing bone cement. So, Khizr, please go ahead.
Yeah, thank you very much. I'll just share my screen. All right. Can you see my screen?
Yes, it's okay.
All right. So I'm Dr. Khizr Ghalib, and I'm a consultant orthopedic spine surgeon in Lahore General Hospital. And I'll be talking about reinforcement techniques for fragile spine fixation. And I think it's not. I think I'll have to. Yeah, all right, it's working now. So the learning objectives of my talk will be to understand the challenges of fixation in a fragile spine and the complexities of these fixations. We will learn the techniques of enhancing the fixation with regard to literature review. We'll have their comparison of these different techniques, and then we'll have some evidence-based recommendation strategies for our participants. So what is osteoporosis? I'll not go into the definition, but the criteria by which WHO classified this osteoporosis, and it was based on BMTT score and the standard deviation from healthy young female. So a T-score of more than 1.0, minus 1.0 is considered to be normal, and minus 1.0 to 2.5 is osteopenia, and anything less than minus 2.5 is considered to be osteoporotic. The problem with the WHO criteria is that it does not explain the more than 50% of fractures that we see in old age people who does not show to have T-score of minus less than minus 2.5. So the National Osteoporosis Foundation came up with their classification, which addresses this problem of fragility fractures, and they classified it as having, if you have a score of T-score of less than minus 2.5, or if you have a fragility hip or spine fracture after the age of 50 years, you are considered to be osteoporotic. And then again, osteopenia is T-score of minus 1.0 to 2.5 in the absence of fractures or high fracture probability with fracture. So this instantly changed the number of the diagnosis of osteoporotic people, and it almost doubled the diagnosis of osteoporosis in spine surgery patients over WHO criteria. So how do we evaluate and when do we evaluate osteoporosis in spine? The indications for bone evaluation are there in the literature. If we have a postmenopausal females, we go for the DEXA scan or the testing for evaluation for osteoporosis. If we have patients who are over age of 65, and then if we have patients with osteoporotic fractures, or if we have any patients with comorbidities, we would always evaluate these patients, and the clinical standard is DEXA scan, but we will get some lab investigations like calcium, vitamin D, and PTH levels. So there is a lot of controversy among the spine surgeons on what to believe in, either the DEXA scan or the Hounsfield units. And the problem with the DEXA scan is that it only gives you a vague idea of the bone quality or the bone mineral density of a vertebra, as it only gives you the quality or the bone mineral density of the cortical shell, rather than the cancellous bone within the body. And usually it overestimates or underestimates this problem. So many of the surgeons, spine surgeons now are turning towards Hounsfield units or obtained from the CT scans, which provide valuable site-specific bone quality data. So this means that you can always, like if we have a vertebral body, we can always see different specific regions and the bone density of these regions, and we can always plan our implants and techniques to fix these osteoporotic bones. So to understand the techniques and the problems that we face, we have to know the pattern of progress of osteoporosis within the vertebral body. So initially, there is always a trabecular bone loss, and which begins in the cancellous bone of the vertebral body. And this bone loss usually occurs 5 to 8 years before cortical thinning of the outer shell of the vertebral body. And in the second stage, the end plates start thinning, and they have a rate of 1 to 2% annually. And the superior and the inferior end plates, they deteriorate. Then in stage 3, the cortical shell of the body, and in stage 4, there is pedicle involvement. And in the last, there is the posterior element thinning of the lamina. So what are the problems that we get with these osteoporotic bones when we fix them? So screw loosening is the major complication, and it is usually due to the reduced bone mineral density and weaker trabecular structure. And this usually limits the screw anchorage, and micromotion and implant stability is much more due to this weak trabecular structure. And then there is impaired bone remodeling and healing capacity. So if there are some microfractures, the bone is unable to heal on itself. So in literature, we see Burke in Global Spine Journal in 2017, they just stated that they did a study on 140 patients for spine fusion, and they found that in osteoporotic patients, there is 46.2% rate of non-union. And there are other osteoporotic complications like kyphosis, pseudarthrosis, fractures, hardware failure, and all that. How do we enhance the fixation in these bones? So always, whenever we think of enhancing our anchorage or fixation, the best way is to do a pre-op bone optimization. And for that, we have anti-resorptive and anabolic drugs available. The anti-resorptive drugs, bisphosphonates, denosumab, they have produced bone loss. They basically work on or hinder the osteoclastic activity, and the anabolic drugs, which is teriparatide and abaloparatide, they stimulate new bone formation. Most of the people now, and all the surgeons or the physicians now, are using both of these drugs in a combination therapy as well. Bisphosphonates, they significantly improve the pull-out strength, increasing bone density approximately about 20 to 30% within a year. And teriparatide has the most promising results so far. Many physicians also use usually the anabolic agents first and then the anti-resorptive agents as to maintain the bone density. So another thing that we take very lightly usually is vitamin D and the calcium levels. So the daily need for calcium in osteoporotic patients above 65 years is almost 1500 mg, and the females above 50 years of age is 1200 mg. And in animal models, it has not been done in human models, but in animal models, it does increase fusion rates, and uh, it, calcium supplementation has not much effect on the BMD. On the other hand, if we look at simple vitamin D supplementation, uh, in research, vitamin D of less than 20 nanogram per ml is associated with increased pseudo and longer term fusion. And higher fusion rates have been seen in patients that are supplemented with vitamin D. Bisphosphonates, again, they show robust fusion mass, but the fusion is thought of to be weaker bone, and it is rendered to the hindering of the or the ineffective remodeling of the bones. That is the reason of the bisphosphonates usually. So most of the surgeons they stop it pre-op, but there is no role of giving bisphosphonates peri-operatively. Teriparatide, on the other hand, is shown to increase the rate of fusion, decrease the losing of rate, screw losing rate, decrease cage subsidence, decrease vertebral fractures, decrease the sagittal balance, and the urinary scale pain. In this study, we see that even teriparatide, if it's given pre-operatively, even on the first day, if we see on the graph, the insertional torque of the screws, it begins to increase. And in 30 days, we have really good strength, and the implant screw out rate is quite decreased. So I'll move on quickly to the techniques and technology. There are a lot of techniques and technology. If we go through the basic surgical techniques, we can increase the diameter of the screw, increase length of screw. We have small pilot hole. We can under-tap the screw. We can use longer constructs. We can supplement it with anterior fixation. We can use laminar hooks or wires and bands. And we can use some trajectories like the triangulation techniques. And then we can have the newer techniques in which we use the CBT, the cortical bone trajectory. We can use the superior cortical screw, double screw, cross screw, and the list goes on. We'll just go through some of these in detail, and which are more time proven. So the best technique, the gold standard, is so far the cement augmented screws. So the pull-out strength in this, if we augment our screws with cement, is increased by almost 149%, and it is shown to be even more in some of the studies. If we compare these the cement augmented screws with the fenestrated cement augmented screws and the conventional screws that are solid, the fenestrated screws show a 20% greater pull-out strength, and this risk of leakage of the cement is thought to be, is rather proven to be less in fenestrated screws. So again, the same. So if we look at here, the technique of putting a solid screw and then a fenestrated screw. If we look at the solid screw, here the solid screw, when we put on the cement and we introduce the pedicle screw, the cement, it usually tends to flow along the surface of the screw, and the chances of leakage of the cement posteriorly and into the canal and in the out of the body is much more. Rather, whereas when we have a fenestrated screw, there is a whole lot of screw on the interior side along the fenestration, and it does not flow along the body of the screw, and the chances of leakage are much less. So what about the distribution of the augmented screw? So where do we put the cement, and how much strength do we gain? So in this study, we see that if the screw is, if we put the cement more proximally and then distally, the distal and proximal augmentation graphs, we see, we'll have a look at them. They show more strength, more pull-out strength than the non-augmented or the screws that are only proximally augmented. So it's always better to have a distal augmentation of the screw, or either a distal and the proximal, but the proximal is again with the risk of having a leakage. So what types of cements can we use for screw augmentation? As Professor Tariq was mentioning earlier, that we have now new cements that are more biocompatible. So what does the literature say about these? So if we look at PMMA, the setting time is 8 to 15 minutes, and the strength is pretty high. The pull-out strength is 250 to 300, and but it is non-biodegradable, degradable, and exothermic reaction. The heat produced can cause neurological damage or even osteonecrosis of the bone around it. So we turn to some biocompatible cements, and the comparison biocompatible cements is we have calcium phosphate and we have hydroxyapatite cement. The problem with these cements is they take longer setting time, as we can see in calcium phosphate and HA, that 15 to 20 minutes and 20 30 minutes. And these cements, they tend to provide this pull-out strength or increase this pull-out strength in a longer time. Like it starts even starts increasing the strength after 10 days in case of the hydroxyapatite. And these are much more costly. So in developing country like ours, these cements are not much feasible. And even worldwide, PMMA still remains the gold standard despite its biocompatibility concerns. Sorry. So there are different techniques, and this technique just came up, and I liked it. And this technique shows to even improve the strength of the screw, the pull-out strength of the screw when we augment it. And initially, we were not using bicortical screws when we were augmenting them with cement. But now with this technique, it shows more pull-out strength, and the chance of leakage is also less. So, yeah. And the windshield effect, basically, when we put a screw that is not bicortical and is unicortical, and there is cement along it, there is a windshield wiper effect, and we see that loosening. And to address that loosening, bicortical augmentation was introduced by the author. So I'll quickly go through the screw design innovations. We have the expandable screws, we have dual-threaded screws, we have conical versus cylindrical screws, and so far the best purchase is which is equivalent to the augmented screws is by the expandable screws, and then again, as we do not use cement in it, there is no risk of cement leakage. But the problem with the biocompatible screws is that they can have a loosening potential on like over time. And if we have to do a revision case, it's really hard to get these screws out again. On the other hand, the dual-threaded screws, they only increase 40% pull-out strength. The conical versus the cylindrical screws, they increase the conical strength for 25%. And these screws, they can be used in osteopenic bone, but not so much recommended in the osteoporotic bones. So, yeah, as I was talking about the cement augmentation and the expandable screws, so in this study, they have compared it and found equivalent results between the cement augmentation and the expandable screws. All right, so then again, to enhance our fixation, we have different types of implant coating technologies, which we have hydroxyapatite, we have titanium plasma spray, biactive glass, and then there are the antibacterial coatings to reduce any subclinical infections. And these screws typically increase from 30 to 40%, and they can be used again in osteopenic bones, but not in osteoporotic bones. They don't have much role in. Then there are the newer trajectories and techniques to put the screws in, and in which many authors have introduced the cross screws, the double screws, uh, in which we take the cortical bone trajectory, put the other screw in the conventional manner, and put a rod with place these two screws within single vertebra, put the rods in them. So these technologies, they are much promising, but they usually tend to like they need a steeper clinical what do you call it learning curve, and obviously they have higher costs as you are putting more implants in it. They are technically very demanding, and the surgery time increases, and the radiation exposure time to both the patient and the surgeon also increase in these techniques. So a little bit about the cortical bone trajectory screws. The advantages of these are this increase the pull-out strength 60 to 70%, and which is equal to augmented screws. There is no cement leakage as we were talking about. The limitations are as it has a steep learning curve. There is a risk of facet violation, limited biomechanical data for multi-level fixation, contraindicated in severe spondylolisthesis, and higher intraoperative radiation exposure. So, in literature, if we go through the comparison, we again find that the cemented trajectory, traditional trajectory, which is mentioned in the red here, if we augment this traditional screw with a cement, it is still far more better than the cortical trajectories and the double screws or the cross screws. So what's the role of anterior reconstruction? So interior reconstruction, if we put kyphoplasty, augment our fixation with kyphoplasty or with anterior cages or with TLIF, DLIF in lumbar spondylosis, uh, these tend to have much better results given their anterior load sharing, their solid fixation. With the solid fixation, we get less micro motions and less loosening of the screws, and they can also help us improve the sagittal balance. And there is lesser screw load in regard to this. The limitations, they increase the surgery time, the morbidity, and the cost. So what about sublaminar bands? So they also provide 35% greater pull-out resistance. But for sublaminar bands to be used, you need to have really good lamina. There should not be any laminar thinning. And then again, you cannot use the sublaminar bands in cases where you are going for a wide decompression and there is no lamina. So another thing that we often ignore while fixing these fixations is the impact of the construction length. So shorter constructs like two-segment fixation or a shorter posterior fixation is bound to go into failure. It has a high failure rate of 35 to 45%, and it's usually at the thoracolumbar junction. If we go above T10 or L2, then it is shown to be a much stable. So we have to be really what I would say is we have to look for the optimal length of our constructs. If it's too short, it's going to fail at the thoracolumbar junction. If it's a medium construct, it increases the pull-out strength. If it's a very long construct, like 5 levels and above, it does increase the pull-out strength of the screws, but on the other hand, we get the adjacent level disease like PJK and PJK. And then again, sagittal balance is very important in these patients who are osteoporotic. We can very well understand that if we have a patient who has positive SVA, and we try to bring it back with just posterior fixation, and we put a lot of stress on the screws are bound to fail. So we need different strategies like putting anterior cages and sharing the load of the screws. We have to know that the rod contouring matches the natural lordosis of the force distribution. We should have like proper alignment distribute forces across multiple fixation points. So if the poor sagittal alignment creates destructive cantilever forces, and proper alignment significantly reduces hardware failure rates in osteoporotic patients. That is in the literature. So what if we compare all these techniques that we have already discussed? So far, the gold standard for osteoporotic fixation is cement augmentation. The specialized screw designs have 50 to 70% of increase in the pull-out strength. The alternative trajectories that we use, like CBT, have 30% stronger fixation, and the supplemental fixation with the sublaminar bands or interior reconstruction, all these, they also have a definite effect, but still, cement augmented screws are the gold standard for fixation in osteoporotic spine. So what are the take-home messages and recommendations? So if we have an osteoporotic spine and we don't have an urgency or emergency to fix it, we should always go for the pre-op optimization. And this is what the literature says, that if you have a minimum surgical plan, like you just want to do a decompression, you should wait at least for 3 months in these patients and optimize the bone. If we have a moderate procedure, that is 1 to 2 level fusion in osteoporosis, we should wait at least 3 to 6 months and do a pre-op optimization of the bone. And if we have big procedures where we have to fix more than 3 levels, 4 levels, 5 levels of these osteoporotic segments, we should wait at least 6 to 12 months. And we should give all these patients the anabolic agents and vitamin D and calcium. So regarding the fixation technique, if we go on with the fixation, if we have a normal bone, then standard fixation techniques typically are sufficient. If we have a osteopenic bone in which there is we have the Hounsfield units between 80 to 120, or the T-score between -1 and 2.5, which is usually considered as osteopenic, we should consider long screws or enhanced thread designs. And if we have an osteoporotic bones, we should turn back to all the advanced reinforcement strategies that we have just discussed. And then again, in the end, even in the post-operative period, we should again turn back to pharmacotherapy of these osteoporotic bones. We should give vitamin D, calcium, and anabolic agents, as teriparatide has shown that if we give it in the post-operative, we started in the post-operative time in period of the management of these cases. At 12-month follow-up, the incidence of screw loosening was 7% to 13% in the teriparatide group. It was 13% to 26% in the risdiplam group, and 15 to 25% in the control group. So we can see that the anabolic agents still take the lead in helping us out in loosening of these implants. Thank you very much. Yeah. I think I have gone through it pretty fast and tried to be concise.
No, I think you've done an excellent job. Khizar, I appreciate your very comprehensive presentation and technical exposition of various sort of thoughts and screws and the trajectories, and mingled with the new cements or various other material in which you can enhance the the basic problem is that aging is not only an osteoporotic problem, there's also sarcopenia. And if you look at the biomechanics, there is always a problem of weak muscles, loss of tension band principle, and development of osteoporosis. And with that, with pathological fractures or just kyphotic deformation, which comes with the age and microfractures coming in various parts of the vertebrae. Just forget about any trauma. They produce sort of abnormal situation biomechanically in which the things get worse and they progress over the period of time. The vertebrae change their shape, they change their biomechanical characteristics. So they are trabecally, they are weak and they are broken. And ultimately, with a minor tumble and fall, they develop osteoporotic fracture, which may result into a sort of a neurological issue, or maybe they present with the difficulty in ambulatory activities. And along with that, the sarcopenia does not add, any, it does not give any help. And in fact, it makes the matter worse. So I think any patient who is going for surgery, in elderly patient, one should consider not only the bony health, status of vitamin D and calcium level, status of vertebrae, which is non-fractured, their BMD level. But I think more than that, the Hounsfield unit, which you have alluded to, they are much more practical and more applicable in surgical side, that if you have a less than 100 Hounsfield unit, then the purchase will be poor and the outcome will be certain degree compromised over the period of time. And if along with that, you can map out the muscle mass at the back and the paraspinal muscles and the iliopsoas muscle, and they all, you can see the muscle mass, the fatty infiltration, and all those sort of situations. They will give you a good idea what is the biomechanical situation in these patients. So you can optimize these patients with a medical treatment, with physical therapy. But I think the problem arises when the patient cannot wait for a long period of time. They need something urgent to be done because they not only there's a trauma there's a collapsed vertebrae, there's a neurological problem or impending neurological issue. And on top of that, there's instability and pain. And if you have to go for long fusion, as you said, that they run the risk of complication because of osteoporosis much more as compared to the simple procedure, one segment fusion or so. So in those situations, I think one must do it and do it in a technical sort of technique, which Kaiser has said, that you can alter the screw threads, or you can change the diameter of the screw, or you can change the shape of the screw, or you can augment the bony structure with something more sort of in which screw can get hold of it. At the same time, they can get bonded to the host bone. So I think it's a very complex situation. And the story doesn't end there. You have to carry on osteoporotic treatment subsequently after the any kind of surgery. Thank you very much, Khidr. Very informative talk. Brigadier Saab, any comments?
Sir, this was a nice presentation, I must say. I just wanted to ask Dr. Khizar, what is your preference in fixation for osteoporotic spines? Is it CBT screws, or it is augmentation with bone cement, or you are using these fenestrated screws? What is the treatment of choice for you?
Yeah, Wasim, when fixing these osteoporotic bones in Pakistan, which is a developing country, and there are financial restraints on the patients, we have to look for the most cost-effective techniques. And given these cost-effective techniques, we always tend to turn back to cement-augmented screws. It's easily available, it's much cheaper than the other technologies. It saves our time, and then again, it has a lesser learning curve. And putting in the CBT screws, I know like you are much more experienced than us and a very, very technically sound person. and you feel pretty easy doing every difficult task. And but on our side, I tend to stay with the more simple, the more time proven, and the more cost effective strategies. We are though trying to procure these fenestrated screws that we can fix percutaneously as well, and very shortly we'll be getting our hands on it. And there's many of the times we do feel like we don't want to open up a case and we need a percutaneous fixation as the patient's frailty doesn't allow us. And so we are trying to get our hands on these fenestrated percutaneous screws. And we are almost there. We have almost arranged them. So that's my take on it.
Yeah, Wasim sir, coming to your question, I think the CBT screw, they are available. They are the
The
same.
CBT, sir, I just want
CBT
to
is
add
just
one
a
thing.
trajectory.
CBT screws are just smaller size screws put in a different direction. They are
Exactly.
cost effective. They are not different screws from what we are normally using screws of 40, 45, 50 size in lumbar vertebra, and in CBT screws they are 35 to 25. So they are smaller screws, they have a lesser diameter, and I think so they are cheap.
And I think
Very,
we
very
have
true.
available.
I would just I would just say that Wasim Bhai is very right. CBT screws are just a different trajectory screws. So what I was referring to is not the cost of these screws, but the time taken to put in these screws in our hands, because we are not very much experienced in putting these screws, plus the radiation exposure, plus the steep learning curve that these trajectories demand. So maybe I will come to you, Wasim Bhai, and learn it from you. I know you are pretty much
You
well.
are always welcome.
Wasim uses, we don't have that luxury. क्यों
No,
जी?
no, sir. This is quite easy. If you start
It's
putting these
easy. I
screws, it's quite
appreciate that.
easy.
I appreciate. I think we have CBT screws here, which are of reasonable standard length, which are available. But I think sometimes we use cement, but cement is, I am not very happy with the cement.
Yes,
But
sir. I am not also happy with the cement because they don't give us that much of strength.
yeah, and when bone खोखली हो तो पावी दियो cement
Bilkul,
बटर,
sir. How can you put in a lot of
it comes
cement
out
inside?
quite easily. So I think in
Exactly.
that respect, if you have a poor bone which is not being stabilized from the back, I think it's worthwhile to go from the front and augment the bone or the anterior column one way or the other, whichever is feasible and applicable and required in those patients. So I think then you can balance the spine from both way, front and back, and you can restore the tension band. At the same time, the post-operative, you should carry on with a bellow, not a bellow, but anabolic treatment. The anabolic drug is very important. It's a little expensive, but it works. Even in a post-operative in which you have not, initiated in previously, pre-operatively, you can start it post-operatively, and it does give positive impact in a bone healing, and a patient doesn't have that much complication as Khizr has already alluded to. Thank you very much, Khizr, and thank you, Wasim Saab. Now we have
It's always welcome, sir.
Shiru. Now we have a young lady, Dr. Fariha Gyas. She is associate professor in radiology in Lama Iqbal Medical College, Jinnah Hospital. She is going to talk about the role of imaging, X-rays, and MRI, and the CT and the bone scan. And hopefully, she's going to tell us more about Hounsville unit. Whether we can do it in an existing CT setup, I think it just needs some different software. The CT probably is the same. Madam, Tashrif laiye. Priya Vyas. Yeah.
Assalamu alaikum and good morning to everyone. I'm Dr. Faria Shams. I'm currently working as Associate Professor in the Department of Diagnostic Radiology, General Hospital, Lahore, Allama Iqbal Medical College. Just give me a moment. I'll be just starting with my presentation. Please accept my apologies for the delay. There was a technical error here. Starting with the definition, osteoporosis is simple reduction in the bone quantity with normal actual bone quality, normal mineral to matrix ratio. Basically, it's just the increase in the porosity of the bone. The bone becomes weak and brittle, and the bone tends to fracture easily, even on minor trauma. That is what basically osteoporosis is. So there are different types of osteoporosis, generalized, regional, and localized. I'll be more focusing on the imaging modalities to assess vertebral fractures here, as I was given the topic of imaging spinal osteoporotic fractures. So we have multiple imaging modalities to look for the fractures, starting from the simple conventional way of X-rays, then dual energy X-rays, which is DEXA, CT, MRI, and then finally bone scan. I'll be narrating some of the differences between DEXA and bone scan as well as a radiologist. I think people may confuse DEXA with bone scan. So what are the basic X-ray features which we look for compression fractures in the spine? This is simple increased radiolucency, which means that the bone is weak. It is decrease in the bone matrix. Increased radiolucency is very, very evident on the simple radiograph on AP and more so on the lateral view. Cortical thinning, and with the cortical thinning and increased radiolucency comes the prominent trabecular pattern. And in that spine, the fractures tend to become more often. And this is very important point that at least 30 to 50% of the bone density has to be lost before it becomes visible on the X-rays. So when a patient comes to us with a spinal X-ray, lateral radiograph, and we report the X-ray as normal, and later on the patient complains of fracture, compression fractures on MRI or CT, then take my words, we as radiologists are not responsible for that, because until unless there is 30 to 50% of the loss in the bone density, X-rays are limited to pick up that diagnosis. There are different methods of grading and diagnosing vertebral fractures. Don't get scared with SQ, QM, and ABQ. I'll be explaining them in a bit. So SQ is semi-quantitative grading of the osteoporotic compression fractures. This is very simple. This is subjective analysis. We actually look at the vertebral height and then compare with the anterior and the posterior vertebral heights together, along with the mid height of the vertebra. If we see visually that there is somewhat around 20% of the decrease in the height of the vertebra, that is graded as grade 1 or mild, between 20 to 40% of the reduction in the vertebral body height, that is grade 2 or moderate, and more than that is severe, which is basically comes under the crush injury, crush fracture. So this is the way semi-quantitative assessment of the vertebral compression fractures. And this is the most common method which is being used in day-to-day practice to comment on the compression vertebral fractures on OPD basis. Second is the cumetic morphometric, quantitative morphometric. In this method, we usually draw lines in different planes, as you can see in diagrams A, B, and C. We draw 3 lines cutting the cortices anteriorly, posteriorly, and the mid body of the vertebra. And then we make different calculations and ratios. And with that, we conclude that there is the decrease in the vertebral height, and it might be a compression fracture here. What is ABQ? This is actually a qualitative analysis, not the quantitative. This is algorithm bone quantitative analysis. In this, we particularly focus on the end plate abnormality. There should be an end plate disruption or fracture for us to declare it as osteoporotic or non-osteoporotic deformity. If the end plate is not involved, it will be a non-osteoporotic deformity, and we simply call it a small vertebral height deformity. As we grow old, we all know that we lose height. That is the reason why, because anterior and posterior wedging of the vertebrae continue along the course of time, and with time we hence decrease in height. That is basically simply because of SVH. So these are different gradings and different names, fancy names, which are given to the compression fractures. It may be wedge fracture, biconcave, and crush fracture injury. As the name indicates very much that it may be anterior wedging, it may be posterior wedging as well. If the height of the vertebral body is decreased anteriorly, it's anterior wedge. If it is decreased posteriorly, it's posterior wedge. And if it is decreased in the mid of the body, that is basically a biconcave fracture. So these are the few pictorial diagrams just to make the audience understand what basically we are looking for in the X-rays. In A, we can see a very nice net pattern of the bone, while in B, there is an obvious decrease in the line pattern, which indicates that the secondary vertical trabecular system becomes enhanced because of the low density of the bone, because of the loss of the bone matrix there, and because the bone is being porous now. Again, these are different presentations of the low density bones coming us for X-ray reporting. It may be vertebral plana when there is both anterior and posterior wedging, and biconcave, giving us a fish mouth appearance. This is simple diagrams of anterior wedging and angular end plate depression from acute fracture as well. There is a deformity which is called bow deformity, that is basically a cartilaginous defect in the posterior aspect of the end plate, because of which there is regression or there is secession of the endchondral, subendchondral bone formation, by the virtue of which that piece of the bone doesn't grow as much as it should. So that gives us actually a bone type formation on the AP radiographs. So these are the simple X-ray illustrations here, giving us very clear decrease in radiolucency and thin cortical bones. However, there is no obvious fracture line which are visible going through the vertebral bodies. So let me be very clear in this slide that compression fractures does not mean that we are going to see a fracture line going through the vertebral body. Compression fractures are simply, there is compression of the trabeculae, micro-architectural distortion, and there are micro-fractures which are not likely to be picked up on simple X-ray. That is the reason we jump onto the other modalities. There's a simple making differences between the hemangiomas, which give us a polka dot appearance, and the pseudohemangioma, which comes with osteoporotic bones. Again, simple wedging, then a plana, and then biconcave, which is fish mouth appearance on the radiographs. Now coming to the next modality, which is DEXA. This is actually what we do in DEXA. What do you understand by DEXA? Which is simple dual energy X-ray absorptiometry. We actually put the patient in the X-ray room and pass different wavelengths of X-rays through the patient, which show different absorptions through the body. The soft tissues will be absorbing some X-rays of different wavelength, and similarly, the bones will be absorbing different wavelength X-rays. And by that, using a software of soft tissue subtraction, we can generate a image which dictates that clearly about the bone density. So it's a very good procedure. It actually gives us the quantity of the bone density and categorizes by giving us the scores like T scores and Z scores. I'll be rating them again in the future slides. But DEXA is very simple to perform. It is quick and it is non-invasive. What I suggest is that if every woman who is not taking HRT and complaining of back pain unexplained, that should be recommended for DEXA scan, because that not only indicates the bone density, but it also estimates the future risk of the fractures by applying VFA, which is vertebral fracture assessment algorithm. So it's simple, quick. It's, there is no need of anesthesia. The amount of radiation is extremely small, even lesser than the simple X-ray. This one point is very important here, and it goes in the favor of the patients who are desperate for looking for the reason of their back pain. This is best standardized method up till now available to diagnose osteoporosis, and it is basically help the physicians to make a decision whether the treatment is required, whether we have to start the treatment in anticipation, or the patient is roaming about with a good bone density. So there must be some pitfalls as well, because the DEXA scan is not recommended for the pregnant patients. If they are pregnant, we cannot recommend DEXA here, and a very, very little chance of getting cancers as well. But to be honest, it's negligible. So we have different types of DEXA, central and peripheral. Central will be focusing on the spine and pelvis, and peripheral to the extremities. And obviously, the central DEXA will be having big machinery, and peripheral will be having smaller units like the MRI coils that we use. They are very small body specific equipment. So this is the point to be stressed here, the T-score calculation and the Z-score calculation. T-score is basically when you compare the bone density of the patient with the bone density of the young, healthy adult of the same gender, not of the same age, but of the same gender. And the adult by which we are comparing the result is young and healthy. So in that score, we will be actually giving you a number that would be between 0 to minus 2.5. If the bone density turns out to be minus 1 to 0, it means the patient is having normal bones. If it is between minus 1 and minus 2.5, it means that the bones are osteoporotic, and more than 0.25 is severe osteoporosis. So basically, we are comparing the density, bone density of the patient with the standard young, healthy adult of the same gender. However, in Z-score, what we do is that we compare the bone density of the patient with the other patient of the same age and of the same gender and the size. The BMI also counts. So that is basically a Z-score. But in our practice, I usually see T-score more often than Z-score. So this is what I was talking about previously as well, that by using DEXA, we can get vertebral fracture assessment as well. DEXA, as you know, is a very low dose X-ray examination. So by using VFA, we can convey the patient that the patient might get future fractures if prior intervention is not being taken. And what are the indications for going for VFA? If the patient has lost more than 1 inch of the height, like if I am 5'7", I am now 5'6". This is a very major indication, especially in the postmenopausal females. Have unexplained back pain, if DEXA gives borderline readings, then we can jump on to VFA because VFA can be performed along with DEXA. DEXA images, obviously, of the spine suggest vertebral deformity and fracture as well. Coming on to the next modality, which is a bone scan. I would be stressing a little bit more on this because what I presume is that many of the doctors must say, not the consultants, I repeat, the doctors, like undergraduates, postgraduate students, they confuse these two terms, DEXA with bone scan. So bone scan is basically radionuclide imaging in which a radiotracer is being used and it is injected in the patient. 10 to 14 days of interval should be there if the patient has previously undergone some contrast study like barium or CT contrast, anything of the sort. So 2 weeks should be between the 2 studies because that may hinder the results. Bone scan is a very good study of detecting the compression fractures because in the areas of fractures, there will be increased radiotracer uptake, as you can see in the scan projected right in front of you. Now, this is a very important point here, which I really want to clear. Bone scan is used to look for infections or abnormal cells like cancer in bone tissue, while DEXA specifically examines bone density to assess the risk of osteoporosis. So in postmenopausal women, we should be recommending bone DEXA scan rather than bone scan. And in cases of osteomyelitis or meds or secondary deposits here or other metabolic like hyperparathyroidism, we would be recommending a bone scan. So this is a simple slide giving you a clue about how the bone scan is performed. It's not very tedious procedure, but yes, it takes 30 minutes or so to do that. And still, I think if we weigh the benefit of the bone scan versus the risk, this is better to go with bone scan. So this is simply explaining what are the objectives of DEXA scan and the duration. That is again a very quick scan, takes about 10 to 30 seconds. And the radiation exposure is very low, significantly less than that of a chest X-ray. And obviously, the procedure is painless. You don't need to even inject anything in the patient's body. The patient simply has to lie down on the machine, and the different frequency wavelengths X-rays are made to pass through the body, and then the images are collected. And then obviously we subtract the soft images, and the bone will be right in front of us on the monitor. Now the next is the CT assessment. Obviously, low-dose CT bone algorithms are now the talk of the town. We do not perform full-dose CT here in the patients in which we want to see osteoporosis. Only low-dose CT is recommended and is being used. It is very quick and fast. Within a minute, the patient goes in the gantry and comes out. It's really readily available even in the government setups. And what is the best advantage of CT? It gives us a very, very good bone resolution, especially about the end plates, which we are looking for any wedging or any deformity. Not very good at picking the soft tissue abnormalities, the discs, and meroedema. The meroedema is the very first radiological sign which appears and picked up on MRI only, and this cannot be picked up on CT. So for very early changes, we must be recommending MRI spine rather than CT, even low-dose CT. So these are the different pictures here, illustrations showing you the compression fracture. As you can clearly see, there is definite decrease in the height of the vertebral body with decreased bone density and prominent trabecular pattern. Like you can see vertical lines running through the vertebral body. These are prominent trabeculae. Again, what do you think this is? Simple compression fractures with increased trabecular pattern and decreased bone density. See this, the picture in front of you is on the bone window and the other one is on the soft tissue window. So we actually give you two windows when we are reporting CT for the osteoporotic patient, the soft tissue window as well, and along with that, we give a bone algorithmic window. So the best modality till date is MRI spine until unless proven otherwise, and before anything else comes now in future, God knows, but this is the best modality till age. Having no radiation exposure, better visualization and early visualization of meroedema along with soft tissue visualization. It very clearly shows the soft tissues, especially the disc area, the prevertebral area, paravertebral, and the epidural space. I must say, epidural space is very clearly picked up by MRI and any nerve compression if there is any. Since we have so many advantages, must be some pitfalls as well, like since it is very costly, availability is an issue, it is time-consuming process because it minimally takes 20 to 25 minutes, and it is very difficult to conduct in claustrophobic patients, and in the facility of the open MRI, the obviously resolution of the MRI drops. MRI doesn't have any bone algorithm, and if the patient is having non-compatible implants and especially the aneurysmal clips, the patient is not actually a candidate for MRI spine, and especially for osteoporosis. So what features we are going to see on MRI? Simply, again, osteopenia, compression fracture, interior wedging, and osteophyte formation. But the most important is the white signal that you are seeing with the right red arrow pointing towards the superior end plate. That is basically the bone marrow edema. So this is basically a sagittal T2 weighted spine image showing you T2 weighted hyperintensity in the lumbar vertebra, wedging of the superior and inferior end plates. And you can see that some osteophytic changes are there as well, which show that the patient must be in middle age group. Here again, I need to make another point that if you want to see the marrow edema, ask for fat set images, not the T2 and T1 only. Ask the radiologist to provide the fat set images as well, because fat set T2 weighted image is the best image to comment upon the marrow edema. And since you can see the marrow edema, it means it's very early osteoporotic compression fracture going on in the patient, and you can manage the patient accordingly, whether by the medicines or whatever, physical activity and whatnot. So these are again the MRI features on sagittal slice T1 weighted sequence. The geographical diagram, which is being pointed out by the pointer, shows low signal intensity in the vertebra near the end plate, inferior end plate. That is basically meroedema area. Along with that, you can compare that with the superior and inferior vertebrae. They are showing normal marrow fat signals. So in conclusion, vertebral fractures are very important and they contribute significantly because to the patient's pain, backache, which is not relieving by anything. It provides a clear marker of impaired bone strength and predictor of new vertebral and non-vertebral insufficiency fractures. Especially in the women of perimenopausal and postmenopausal area. Those are the women who are going through this terrible pain day in and day out. And since the radiograph is not going to pick until and unless 20 to 30% of the bone density has been lost already, sometimes the family gets disappointed and frustrated that since there are no changes coming up on the radiographs, the patient might be malingering. Take the women complaints seriously, please. Just a message to all the consultants here. If your wife, if your mother, they are complaining of back pain, which is unexplained, go for the DEXA scan at least. Again, there are multiple things that we can look for on the X-rays and on the CT, DEXA, bone scan, and MRI. But in all the modalities, the best modality still is MRI. So if you have a good facility of MRI, which can provide you a better soft resolution, why not to go for that? Earlier, the better. We can refer the patient to you if we diagnose the patient earlier. So as a radiologist, just a confession that you are the physicians who can treat the patient. So we are the doctors who can send the patients to you for better and early intervention. Thank you very much.
Thank you very much, ma'am. Very comprehensive on एक हैंसविल यूनिट ਦੇ ਬਾਰੇ ਤੁਸੀਂ ਕੁਝ ਨਹੀਂ ਕਿਹਾ ਹਾਂਸਵਿਲ यूनिट अच्छा चलो you see the BMD, as you have already said that, and we have seen in it's not sort of a standardized measure anymore. There have been a lot of sort of variations, and patient they have a good sort of score, but they still have problems with the osteoporosis or the osteopenia. But the CT scan with a Hounsfield unit, that appears to be much more correlated with the surgical scenario in terms of the internal fixation outcome in the terms of any further collapse or non-union or delayed union. Because that tells us more about the osteoporosis, which is related to the outcome as compared to if you have a less than 100 Hounsfield units, the prognosis is poor, and they always say that you should improve it before surgery if it's feasible. But anything 120 is something which is more desirable for the surgical treatment scenario. क्या ख्याल है आप? चलो. Thank you very much, Friha. Very comprehensive talk. Now I invite Professor Yuki Anazawa. He is a professor and director of orthopedic surgery in Tokyo Dental Hospital, Ichikawa General Hospital, Tokyo, Japan. He is a very good friend of ours, and he's offered and we have accepted to have a joint sort of exchange fellowship program, and we'll soon be sending one of our boys to
to his unit, so that we can learn from his experience and expertise in an hospital. Professor Anazawa is going to talk about emerging therapies in osteoporosis and spine care. Professor Anazawa. Professor Anazawa. Oh, look at that.
This picture is a restaurant meeting. Hello, everyone.
Video
Bone strength is determined by bone mass and bone quality, with bone density accounting for 70% and bone quality for 30%. When the bone mineral density standard deviation is below -2.5 SD, the patient fracture rate exceeds 30%. And so less than -2.5 SD groups is high risk group for fractures. In Japan, a bone density value below -2.5 SD, high risk group is commonly expressed as being below 70% of the young adult males. Yeah, of bone density. And this is the relationship between the frequency of proximal fractures and bone mass categorized by age. You can see even in the group with bone mineral density of -2.5 SD, fracture rates vary by age, with higher fracture rates observed in older groups. Why? The answer is bone quality. Bone quality includes structural and material properties and others. We need to understand that in osteoporosis patients, bone loss is not limited to a reduction in BMT, but also involves changes in microarchitecture and bone material properties. This explains why even patients with good BMT can have complications such as compression fractures after spinal surgery, especially in elderly patients. And osteoporosis treatment drugs. The first one is SAM, androgen receptor modulators. It has been reported that it may improve bone quality. And bisphosphonate, denosumab, anti-lung antibody, peptide hormone, PPS, peptide. And last one is romosozumab, anti-sclerostin antibody. Those drugs classified into three categories based on pharmacological types. The first one was anti-resorptive agents. One is bisphosphonate, also class inhibitor, and next is denosumab, also class formation inhibitor. They show suppression of bone turnover. Another one is bone resorption inhibition and bone formation promoting agents, romosozumab. Denosumab only approved in Japan in 2019, new drug. And last one is non-formation promoting agent, Departide, TPH, approved in Japan in 2010. And in Japan, the indications for these two bone formation promoting agents are currently restricted to patients with osteoporosis with a high risk of fracture. The restrictions on the duration and number of administrations. The treatment period is approximately 1 year. It can only be used once in a lifetime. What is a high-risk fracture osteoporosis? Severe osteoporosis. WHO defined it bone mineral density BMD of less than -2.5 SD, yeah, 70%, with one fracture T fracture. And different diagnostic criteria for primary osteoporosis, if we take it, one is lumbar spine BMD of less than -3.3 SD, yeah, is 60%. Or 2 or more existing vertebral fractures, or a grade 3 severe collapse without in the semi-quantitative evaluation method of existing vertebral fractures. A grade 3 severe collapse means reduction of more than 40% or decrease of more than 40%. Severe osteoporosis will be determined not only by BMD, but also by the history of fractures. On treatment of osteoporosis in Japan, the first stage, gradual bone loss mid 40s to early 50s, some first choice to improve bone quality. And next stage, accelerated bone loss occurred in the 50s, some and to maintain BMD by suppressing of bone turnover. And next, continued bone loss in the 60s with flight and denosumab. Furthermore, wound formation agent was used to improve BMD in severe osteoporosis. And the last stage, severe osteoporosis risk period over 70s. Wound formation agent for severe osteoporosis. And for severe osteoporosis, wound formation agents can be used only for 1 to 2 years. And so we need to switch to standard therapy with the following drugs, flight and denosumab. And little management is necessary to prevent jaw osteonecrosis, so-called medicated related osteonecrosis of the jaw and longer, and no complication. And the feature of bisphosphonate, the drug remains in the bones for a long time and suppresses bone metabolism, making a drug holiday necessary after 3 or 5 years. A complication is bisphosphonate-induced severe suppression of bone turnover, SSBT, which can lead to atypical fracture. Another one, denosumab. The feature is drug termination should be approached with caution due to the reduction effect, a rebound effect of bone turnover suppression, as rapid proliferation of osteoblasts may occur, potentially leading to a sudden decrease in bone mass. And the next, let me show the case presentation. The 77-year-old DMD young is 100%. Very good condition, BMD. We have no complication after surgery. Next patient is 77-year-old. Also showed BMD is 93% due to BMD condition. However, only post of 1 week, we can see case subsidence due to bone weakness. This case shows us that although bone mass can be assessed, bone strength cannot be accurately predicted. Therefore, we are compelled to rely on clinical symptoms, particularly a history of fractures, to determine bone quality. And in Japan, 2010, bone formation promoting agent, PTH, has been approved. This is a report of different session enhanced by intermediate treatment with parathyroid hormone. Our right side picture treated with PTH. The density of the trabecular network around the implant is greater is treated with PTH. You can see. And they show the renewable torque of screws and core strength increased after the administration of TPH. This is a 78-year-old man, L3 vertebral pseudarthrosis, and treated with posterior fixation. However, post of 3 months, a screw displacement appeared. Revision surgery was performed with extension of posterior spinal fixation. Administration of BP agents was initiated. However, after 3 years, severe low back pain occurred. We can see L1 compression fracture. So, implementation of BP efficacy. And we switch to daily PTA therapy. Under the daily PTA therapy, 1.5 years after administration, no back pain without surgery. The combination of PTH may be effective in spinal surgery for severe osteoporosis. This is on MOB case. 57-year-old female with spinal stenosis. He complained low back pain and leg pain, and the patient can only walk by holding onto support due to pain. However, lumbar YAM is 144%. Very, very good MOB condition. However, medical history, SLE at age 18. And he was treated with oral prednisone. Initial dose is 60 milligrams per day, and current dose is 10 milligrams per day. And he has throat-induced diabetic mellitus, and he has history of surgery, bilateral proximal femoral fractures. He was treated with PLF from chest 10 to S1 with decompression. However, after only 1 month, he had severe lower pain. And you can see S1 pedicle fracture. And he was treated with regional surgery and insertion of iliac screws. And intraoperatively, losing of the L5 and S1 screws was confirmed. And tripartite TPH was administered. Close to 1 month after regional surgery, TX tab fracture appeared. And we could use second regional surgery. Removal of the chest tab screw and the 7 to 9 extended fixation was performed using the 7 hooks instead of screws. This approach was chosen because using screw fixation at the proximal end increased the risk of proximal junction kyphosis with the cat. However, because of 1 month fracture at THH and displacement of the foot appeared. And so we treat sad regional surgery. TH5, TH8, manoplasty, and sublunar tape fixation from TH6 to TH8. And we treated with PTS administration. Over 2 years, there are no programs for the patient. However, 3 years after the last operation, we have an infection. Despite the replacement of irrigation and administration of antibiotics, no improvement was observed. Complete removal of implants was performed. Yeah, now Japanese spinal surgeons still keenly feel the challenges of osteoporosis even to this day. Now I'm challenging. We use now trabecular bone score TBS mapping. A diagnostic tool used to assess bone quality, specifically the microarchitecture of the trabecular bone. It is derived from standard DXR images. And post-operative use of bone formation agents, including teriparatide and romosozumab, in elderly women treated with spinal fusion surgery. Furthermore, it's very important osteoporosis liaison service OLS activities. OLS composed of multidisciplinary team, including physicians, nurses, dietitians, provides comprehensive management. The team offers guidance of osteoporosis medication and nutrition intake before and after spinal surgery. Conclusion. The emergence of new osteoporosis treatment drugs, including bone formation agents, may initiate a new era in spinal osteoporosis therapy. However, a definitive solution for complications following fixation surgery in patients with severe osteoporosis has yet to be established. Although bone mineral density (BMD) can be measured by DEXA, the evaluation on bone quality remains an unsolved issue. Thank you, everyone.
Thank you, Professor Anazawa. I think it was very comprehensive and very interesting presentation, and you very rightly highlighted new drugs, new method of fixations, and address the problem of osteoporotic fractures in a very rational way. We appreciate your presentation. Now we have Professor Brigadier Wasim Afzal, who is the spine surgeon in Rawalpindi, CMS, and he's going to talk about instrumentation challenge in osteoporotic spine surgery. Brigadier Saab, ਤੁਸੀਂ ਹਾਲੀ ਹੈਗੇ ਹੋ ਕਿ ਨਹੀਂ?
Sir, with you.
Please go ahead.
सर ये प्रेजेंटेशन काइंडली आप नदीम से कहना लगा दे।
चल भी नदीम लगा दे।
जी सर, आपने मुझे भिजवा दी?
आपको भिजवाई थी ना कल?
जी जी सर, बिल्कुल।
आपने साथ साथ चलाते जाना है इसको।
श्योर सर, श्योर।
अच्छा, ठीक है।
तो स्लाइड शो पे काइंडली लगा दें।
जी सर।
अच्छा,
So please start. You can start, sir.
First slide, please. Thank you, Dr. Sohail and your team. It's a real pleasure talking about osteoporosis with all my colleagues. First slide, please. I've got no financial gains or any relations. The learning objectives today would be understanding the scale of the problem of osteoporosis. We classify and score the osteoporotic fractures what in form of management strategy. Knowing about the available surgical techniques and implants, we understand their indications and limitations. We should be aware of important procedural concepts in order to minimize the risk of failure. And we should be familiar with the strategies for preventing future complications. Next slide, please. Osteoporosis is basically defined as a systemic skeletal disease characterized by low bone density and microarchitectural deterioration of bone tissue. Extending from picture A to C, you can see the density has decreased and the architecture has also decreased. So this shows where the mineral density as well as the osteoid formation that has been decreased. Next slide, please. Nadeem, next. We characterize this thing by DEXA scan, which shows that it is minus T-score of minus 2.5 or less. In severe osteoporosis, we characterize it by osteoporosis associated with one or more fractures. Next, please. It is basically number one disease amongst the women, especially the older women. And in men, it is number two. It is 3 times more common in women than men. So it is, we can say, primarily a disease of women. That is because of the post-menopausal characters and the decrease in the hormonal concentrations in them. Osteoporotic fractures are the hallmark of osteoporosis in addition to all those limb fractures. During their lifetime, up to half of the women and about 1/3 of the men will develop vertebral body compression fractures, and half of the affected will develop multiple fractures. So it is a very common disease in older people. at 75 years of age, 25% of the women will have one vertebral body compression fractures, and at age of more than 80 years, it increases to 50%. So it is almost, you can say, 100% increase in the vertebral body fractures. Uh, if we have one single vertebral body compression fracture, there are 4 times the chances of getting a second fracture. And if we have two fractures, the chances increase to 12 times. So this significantly increases. Next, please. Uh, the German Orthopedic and Trauma Association has classified nicely. There are many classifications, but this was the most simple and most applicable classification which I could find. In type 1 osteoporotic fractures, there's no deformity, but only edema that can be seen on MRIs. In type 2 fractures, and one of the end plates is involved, either upper one or the lower one. Along with that, less than 1/5 of the involvement of the posterior wall is there. In type 3 fractures, the involvement of the posterior wall is more than 1/5, along with one end plate. In type 4, two end plates are involved with or without posterior involvement, whether they are less than 1/5 or more than 1/5, it doesn't matter. In type 5 fractures, injuries, there are anterior or posterior tension band injuries. Next slide, please. These are the picture images of what we have discussed. First one is edema inside the body that can be seen only on MRIs. Then going to first end plate, either upper one or the lower one, and the posterior wall involvement more than 1/5. Next slide. Then either the both end plates with or without involvement of the posterior wall. Then the posterior ligamentous complex involvement or the anterior ligamentous involvement is there. Next slide. This is the algorithm of the same thing where we find what is involvement. If it is involving one end plate, it is type 1, type 2. Then if it involves the posterior wall also, it is type 3. If it involves both the end plates, it's type 4. And the ligamentous complex is involved, then it is type 5. Thank you. Next. The German Orthopedic Association trauma score, they have devised a plan also which can give us a score so that we can help the younger colleagues or the patients in devising the treatment plan. It involves the T score, the progression of deformity, pain under analgesia, neurological deficit, mobility of the patient with analgesia, and general health status. We go on to the score now. Next, please. Nadeem, next. These are the parameters, the morphology going from grade 1 to grade 5. Each one is given a score of 2. Then the severity of osteoporosis, whether the T-score is more than -3 or it is less than -3, we give them a score of 1. Then the deformity progression, pain and under analgesia, visual analog score of more than 5 or less than 5. Then neurological symptoms, what we are seeing over there. Mobilization is there or it is absent. The general condition, this we take it from ASA, the American Society of Anesthesiologists score of more than 3 and less than 2. If the score is 0 to 5, we go for conservative treatment. If it is 6, then it is choice of the patient. You can go for surgery or some intervention, or you can treat them conservatively. But more than 6, it is recommended that you go for surgery or some kind of intervention. Next, please. This is the treatment recommendation. In type 1, normally the score is less than 5 or it is non-surgical most of the times. In type 2 fractures, if the score is less than 6, non-surgical, and if it is more than 6, you can go for cement augmentation. But in type 3 fractures, short segment fixations or posterior instrumentations are done, but it is recommended that long segment fixations should be done for type 4 or type 5. Next, please. So, the non-surgical management consists of bed rest of more than 3 to 6 weeks. Then analgesics are given to the patients along with calcium and bisphosphonates. Bracing for patients who want to be mobilized early, or there is some gibbous formation over there. Follow-up of the patients is regarding pain, progressive kyphotic deformity, or loss of sagittal balance. So, along with this, we give them calcium, vitamin D, bisphosphonates, the hormone replacement therapy, just like PTH and denosumab, or then estrogen hormone analogs can also be used in females. Next, please. Coming on to the fort of the surgeons, that is the surgical management. What is in our arsenal and what to look out for and how to avoid the potential complications. Next, please. So the first and foremost thing is the vertebroplasty. We put in the bone cement in situ with no correction of kyphotic deformity or correction inside. With kyphoplasty, 8.5 degrees of correction is there. With lordoplasty, it increases to 14 degrees. In all these three things, we normally put in bone cement. Thank you. So the indications for kyphoplasty or lordoplasty or vertebroplasty, whatever you use, the pain should be more than 2 weeks. The patient should be bedridden for more than 4 days, or you are suspecting a progressive vertebral collapse. Non-union is occurring with persistent instability, what we see in Comel disease. Thank you. So the contraindications, if you suspect the pain is unlikely to be related to a fracture or it is associated with some other pathologies less like tumor, some infection is underlying there and it can flare up. Some clotting disorder which can increase the condition of the patient or deteriorate it. Neurological deficit which is an indication for open surgery. If the patient is too bulky or too obese and you cannot see the pedicles clearly, then don't try this vertebroplasty or kyphoplasty. Poor general state of health and inability to lie prone is another contraindication because the patient has to lie there for about half an hour for in a prone position, and it is a painful procedure. Uh, so a patient should be in a good condition to tolerate this ordeal. All this thing is done in local anesthesia, remember. Thank you. So this is a pictorial thing of what we do in vertebroplasty. We put in needle and then we put in bone cement. In kyphoplasty, we have a balloon. Then we make space with the balloon and then we put in bone cement. Next, please. In lordoplasty, we correct it. We put in these needles and we lordos the spine in a position so that before coming out, we correct the normal alignment of the spine as well. So it gives better results. Next, please. So the complications associated with cement augmentations are anesthesia related. If a patient is of an old age and is lying there for about, then there are few complications that can happen, or this cement can leak into the blood vessels, and even we have seen at times this goes into the lungs. Then technique-related complications are there. The pedicles can fracture, the spinal cord injury due to malpositioning of cannula can occur. The cement leakage into the canal can cause irreversible neural damage because of the exothermic reaction of the bone cement. Cement embolization can occur to any place once it goes into the vessels. At times, the patients are hypersensitive to bone cement, and this can cause a severe anaphylactic reaction. Infections are there, and adjacent level fractures are seen post-operatively. Once a segment which has got a bigger strength now in between, that can cause compression onto the adjacent segments. Next, please. Guidelines to avoid these complications are that we should not put more than 3 to 5 cc's of cement per vertebral body. It is recommended that in a single sitting, 6 or less vertebrae should be treated. The maximum amount of cement should not be more than 25 cc's. A high viscosity cement or balloon for cavity creation should be used to avoid cement leakage. Here, I would like to share one of my own cases. He was our senior colleague from radiology, a very fine gentleman. He was 78 years of age. He had osteoporosis. There was no significant comorbids. He was a chain smoker. Neurologically, he was intact, but even after 6 weeks of these osteoporotic fractures, he was not being cured of pain, and it was difficult for him to be mobilized. Next. These are the X-rays where you can see in the lateral view clearly that L3 is compressed, and I would call this thing as type 4. Next, please. We introduced that stellate inside. Then you can see the balloon in the second picture. In the third picture, there is the balloon has been inflated. Next. Then we see the cement going in. There is slight leakage anteriorly, but we are not worried about it. We had used from the both pedicles, so there was the fine amount. We had placed about 5 cc of bone cement in the vertebra, and this was the final picture. Operative surgical options are posterior spinal fusion, along with vertebroplasty. This can be a very good option. At times, we need anterior spinal fusion as well because the anterior column takes the brunt of about 80% of the body weight is borne by it. So at times we need anterior fusion as well. Combined anterior and posterior can be done, or we can go for VCR, but it has to be taken care of by a long fixation. Whenever we want a correction of weight alignment and we want to correct the pelvic tilt along with the lumbar lordosis. So this is a big undertaking. One should be careful about it. So the basic implant fixation and hardware operations in osteoporotic fractures are we can always go for a bigger size diameter, increasing the length, the small pilot hole, and then putting in the screw in it so that we don't make a wider hole so that it get loosened up. Under tapping the screw so that we go with a good fixation. A longer construct, 3 above and 3 below, but the practice varies from person to person. Laminar hooks and wires are a great help because the lamina, they are very strong in these cases and they give us good strength. Then we have got transverse connectors, and triangulation techniques of screws can be also helpful. Next, please. Then there are few other coming up techniques, just like CBT, that the cortical bone trajectory screw, the superior cortical screws. We go inside the cortical bone, just along the end plate. Then we can put in double screws uh, in the same vertebra. Then the cross trajectory screws, the bicortical screws can be used. Then the cement augmented pedicle screws can be used, but I don't prefer these screws because I have seen that uh, although there is a lot written in the literature, but practically they don't help. These are the pictorial things of what we do. This says basically CBT screws, how we put in from 5 to 11 degrees on one side, and the other side it is 7 to 1. So they are taking, you can see they are taking about 4 cortices on each side. So it gives you a good strength once you put in these screws. Next, please. These are a picture of double screws. Then we can give them strength by putting in double screws so that the pull-out strength is easier. At times, you require bicortical screws, cross trajectory screws, where you can see that they are at an angle to each other so that the pull-out strength is increased. Next, please. Cement augmented screws, they are cannulated screws where we put in the cement inside and then we put in the screws. We are not using these screws normally. The hardware operations, there are few things that are coming up nicely. The expandable screws, fenestrated screws, the conical screws with or without dual threads, so that they have got different pitch and the whole pull-out strength that increases. Then the coated screws of hydroxyapatite. Uh, we don't have these screws, but they are given in the literature. Next, please. A picture of these expanding screws. Once they go inside, they expand and give you good strength. These are biomechanically better screws than the screws with the bone cement augmentation. Next, please. These are the pictures of fenestrated screws, the conical screws with dual pitch, and the coated screws of hydroxyapatite. I would like to share another case of mine where we had a problem of this 57 years of old lady. She had osteoporosis. She was diabetic, and she had multiple strokes, after which she had epilepsy also. So there were few things which were beyond our control, but it was a poor case. So she was on antihypertensives, anti-epileptics, anticoagulants. We had to stop anticoagulants before surgery. TLIF was done elsewhere for spondylolisthesis, and this was complicated by infection and subsequent implant failure secondary to osteoporosis. She was bedridden, and this was. Can you go to the X-ray, please? Next. These were the X-rays once she came to us. You can see the implants are malpositioned, and I thought so that the ones on the right, they are going into the canal after cutting out the pedicle. So we removed them. This was, next slide, please. These are the CT scans of the same patient. You can see the erosion in the bone, and this was a difficult patient. Next slide, please. This is what we did. We had to extend the construct low down to S2 iliac screws so that we get strength from down. And above, we have used the CBT screws. The CBT screws on the right side, you can see they are from 511, and on the left side, we have used the angle of 7 to 1. So this has worked, and she is quite comfortable. The last time I talked to her about 2 weeks back, and she was mobile. So this was a big achievement once a patient who was bedridden to somebody who is mobile now. So although she is walks with a stick, but this is a great improvement. Next, please. So what we need to learn from these things that we need to go for once we are going for fixation, we can do a biopsy first because at times there are malignancies and especially plasmacytomas or such kind of things. So a biopsy can help you a lot. So prophylactics, augmentation of body above and below, uh, at times helps us in adjacent segment diseases, but you have to take the consent for this thing beforehand. When using fenestrated screws, make sure the screw tip is far enough from the anterior cortex and end plate to allow space for the cement to work. So you have to take care. Otherwise, it leaks out of the body of the vertebra. In long constructs, take caudal end L5 to avoid potential kyphotic collapse. And you can always go to S2LR iliac screws because they give a good strength. Avoid using traditional interbody cages as there is a problem of subsidence that they sink into the body. So whenever you are trying to put in something there, a bone graft is a better option than these cages. Next option. Uh, what I would like to tell you to somebody who wants to learn this thing that surgery is only reserved for the patients who need it. And the most commonly, it is not required in osteoporotic patients. So it is a very small number of patients who are not treated by medical treatment, those who land up with the surgeon. Uh, it is not isolated spine that is a surgical problem. It needs a multidisciplinary approach. You need to involve the radiologist, you need to involve the endocrinologist, a rheumatologist, and the rehab specialist. So once the spectrum is complete, the recovery of the patient is expedited. Thank you very much, Nadeem. Sir, बहुत शुक्रिया.
I think the last two, the take-home message was absolutely fantastic. It's not a one-man show. It's not a one-man sort of treatment or management. I think it's a multidisciplinary approach has to be taken in these patients so that you can offer not only from mechanical, biological, but also other aspects because the bone is still the primary seat of disease and it is gone. It is very degenerate, and you have to take care of the degenerate spine and the poor regenerative capacity of the bone to sustain itself. So I think it's not only just a spinal issue, it's only also of a geriatric problem, medical problem. To a certain extent, you have to take care of other like anabolic drugs and maybe some other monoclonal antibodies which have come up in the market to take care of this osteoporotic bone. And I think one has to anticipate there will be some problem at some stage because some logistic reasons, but also from the aging process and other issues which not unusually they have in these kind of patients. So I think it's a very, very interesting talk and very comprehensive talk. I really enjoyed it. Thank you very much for your presentation and talk. And thank you very much for your time and wish you all the luck in your future endeavor. Thank you. Kyunji Gala sir?
I do have some questions from Dr. Wasim, as he is much more experienced than us, and it is a good chance of getting some knowledge out of him. Wasim, what is your take on many of the times in clinical practice that we see a patient presenting to us with not one but two osteoporotic collapse fractures, and sometimes they might be fresh fractures, and sometimes they are one is old and one is fresh. So the collective kyphosis usually is that we see is very significant. So what is your threshold of fixing in such patients with two adjacent osteoporotic fractures, either fresh or one old, one fresh? What is your threshold of fixing these?
If the fracture is painful, Khizr, we normally fix them within 2 weeks, because pain is the foremost thing. And diagnosing anything fresh from old is very easy. You get just a bone scan and it will tell you if it is a hot spot, it is a new one. If it is cold, then it is an old fracture. So you don't need to fiddle up with the old one. Just fix the new one. Once you put in the bone cement, it burns the nerves as well with the exothermic reaction, and it gives stability also. So these two actions, they cause pain relief to the patient, and his life is good enough. But they don't have much to do in life. They just want to have prayers and they want to go to the washroom. This is what their life is. So if you make them comfortable, you will have lots of good words from them.
Yeah, but my question actually is that when we see two osteoporotic collapse fractures together, even if we single out one of them and they don't have much of kyphosis, collectively they have a much more kyphosis.
Khizr, I understand your question, but I think I do appreciate that if you have a fracture which is already healed, just ignore it and treat the new fracture which is painful. But having said that, if you have a two fracture which are producing kyphotic deformity, which is producing neurological tissue at risk and creating a lot of biomechanical imbalance, then I think on top of that, treating that new fracture, one should address with the either with the instrumentation or, if needed to, for any kind of osteotomy. But don't forget that in elderly patients with osteoporotic bone, even the VCRs and etc., this kind of osteotomy, they have much more complication, and the corresponding results are not as good as one would like to see in future.
Sorry, my connection was lost.
ਮੈਨੂੰ ਲੱਗਦਾ ਤੁਸੀਂ ਕਿਤੇ ਗਲਤ ਜਗ੍ਹਾ ਤੇ ਬੈਠੇ ਹੋ।
ਨਹੀਂ ਸਰ, ਪਾਕਿਸਤਾਨ ਬਿਜਲੀ
ਪਾਕਿਸਤਾਨ ਤੁਹਾਡੀ ਜਿਹੜੀਆਂ ਨੇ ਨਾ, ਇਹ ਤੁਹਾਡੀਆਂ ਰਿਪੋਰਟਾਂ ਮੈਨੂੰ ਮਿਲਦੀਆਂ ਰਹਿੰਦੀਆਂ।
If you want to fix osteoporotic fractures, then you would land up with longer fixations. So be prepared for it. 3 above and 3 below.
Yeah.
Then if you want to correct the alignment, you want to have a pelvic tilt within normal limits, and if you want to have the pelvic incidence minus lumbar lordosis within 10 degrees, then you need to have pedicle subtraction osteotomy. So if you are willing to go for such big risky cases, then go for it. There's nothing wrong in it. But the fixation would be longer.
Right.
And I think complication in our setup is also there. The complication rate is the patient doesn't comply with your instructions. They once they go home, they do whatever irshadar das dene ki ya karo ya na karo. They are not very compliant group of patients. So I think you have to take very carefully that if they want osteotomy or not. If you want to do an osteotomy or not, I think in two adjacent, one old and new, if they produce significant deformity, yes, I think one can go for posterior fixation. Again, as Wasim has said, that it should be a little longer fixation because the stress distribution will be much better as compared to if it's just a short fixation. Short fixation in a younger patient is okay, but in an elderly patient, it produces adjacent segment problem, and the failure is significant because the bone is poor.
So my second question would be on the CBT screws, of course. So, because you are much more experienced in CBT use of CBT screws, uh, much of the literature says that CBT screws do not have a pull-out strength of those of cement augmented screws, and so the CBT screws can only be used in osteopenic bone rather than a severely osteoporotic bone. What's your take on it?
We have used, because I have shown you the picture. In CBT screws, you have 4 cortices that are involved. Once you enter the bone, then the posterior cortex of the pedicle, anterior cortex of the pedicle, and then the end plate. So these are the 4 cortices that are involved. In a single pedicle screw, you just involve one cortical bone. That is the posterior cortical bone. So once it's inside the pedicle, the bone is all gone. The architecture is failed. Then inside the body, you always say that 2/3 of the body should be involved by a screw. And inside, it's all hollow. So there is no hole inside. So once you compare the 2 screws, one which is having 4 cortices and the other one which is only having 1 cortex, the strength is more here. So I would say that I have not come across some article in which they have compared the CBT screws with the cement augmented screws, but I'll look into it again. My personal experience with the bone cement is not good because there is a cavity inside, and you do not know how much cement has gone in and how much it will hold. Then the screw pitch, वो जो उसकी चूड़ी होती है, it has to be a bigger sized. It has to be a cancellous screw type so that it
Has to be
holds
bigger
that
type.
bone cement inside. So we are missing on that part also because we are using normal screws with these bone cements. These are not large pitch screws. So I think so. It is not working in our hands because we are not using the right kind of screws.
Okay, thank you very much, gentlemen. We think we had a very good session, and we had a very healthy and fruitful discussion. And I learned a lot from all these deliberations. I thank Wasim, I thank Khizar, I thank Shunji, and I thank Professor Anazawa, and thank Dr. Freya, who's taken a lot of time and effort to prepare the slides and present our talk today. I thank all the colleagues of mine, friends, or those who are online to participate and be with us in this important symposium. And we hope to carry on the same next month or so. Thank you very much indeed. Thanks a lot.
Thank you, sir.
Thank you.
Thank you, sir. Thank you
Khizar.
very much. Thank you, Wasim bhai.
Thank you, Khizar.
Okay, sir.
Allah
Thank you.
Hafiz.
Allah Hafiz, sir. Thank you.
Thank you, Nadeem.
Thank you, sir. Welcome. Welcome, sir. Thank you.